Today, I think what I'll do in order to introduce all the DHHS and NPHL staff, we'll do that as we go through the topics and introduce the topic and ask them to step forward to speak. So again, really glad that you guys are all able to log on this morning. Kind of a dreary Monday morning. First off, I wanted to see if Jeff is on the line.
He was.
And I don't hear from him, but he said he probably would join at some point. So we will go on. Is Matt on?
Hi, Karen. This is Brian. Matt said he's going to be on, but it's going to take about 10 minutes. So
right.
if you wouldn't mind going to Sadie or Brianna,
yes,
and catch up with him later.
Yep.
Thank you.
No problem. Thanks for letting me know, Brian. With that, we'll keep moving on our agenda to other outbreaks. Sadie or Brianna? I think I saw Brianna for sure.
I'm on. Can you hear me?
Yes, I can. Go ahead and just introduce yourself and go ahead.
Yeah, I'm Brianna Locke. I'm one of the enteric disease or the foodborne, waterborne EPIs at the state. And I see you have norovirus on the agenda, but good news, we have seen a sharp decrease of norovirus outbreaks reported. Over the last 3 weeks, there's only been 2 outbreaks reported across the state. So we're very happy about that and hope that continues throughout the summer. But of course, then on the flip side, we worry about other pathogens like cyclospora or salmonella, S-tech, crypto, those increasing. So just a reminder, yes, to please send all your positive GIs or such as salmonella, E. coli, cyclospora, crypto, to the public health lab so we can do further testing on those.
All right. Brianna, thank you. Yeah. Any questions for Brianna? All right. So just a reminder there to don't forget to send your positive GIs. Make sure you send them on a daily basis because they are only good for 3 days, 72 hours. The sooner you can get them here, the better we do the recovery. And they are not always easy to recover.
Karen, this
yes.
is Emily. I just wanted to add to that real quick. Not only are we asking you guys to remember to submit your GI pathogens, but please remember to follow any pathogen listed on Title 173 for required submissions to NPHL. If any of your laboratories do not know what I'm talking about with Title 173 or do not have an updated quick sheet, please reach out to Karen or Brianna. They'd be happy to provide one for you.
Exactly, Emily, thank you for that. In fact, it is listed, the most current one is listed on our website. If you go to the left-hand side where the menu is, you'll see an item for reportable diseases. And both the quick sheets are listed there, but also the full list of the Title 173 requirements. So you can refer to both of those, but if it's just easier to call or email, we're certainly okay with that. All right, I would like to take it back up now and ask Jeff to speak a little bit on just the tick surveillance and what comes with those ticks. And we're glad to have you on, Jeff, if you could introduce yourself.
Yeah, hi Karen. Hey everyone, apologies for being late. I was on another call.
Not a bad.
So yeah, as Karen kind of mentioned there, you know, we're doing some tick surveillance. We've been going around the state collecting ticks from across sites, and just, you know, basically trying to get a better idea of kind of what ticks are out there, where they're at, and just getting that distribution down. You know, we don't know about testing for pathogens. If we come across any black-legged ticks, which are the vector for Lyme disease, we're free to send those to CDC to have those tested. However, for other ticks of interest, they're not testing any of those. So we're kind of hoping we can maybe find some funding, here and maybe, be able to test them in the future. So that's kind of on hold right now. Right now, the main thing is to kind of get an idea of what species are where. And so we've hit about 20 sites across the state. The ticks are definitely active. It's definitely tick season. Some places, in an hour or so worth of work, we can collect over 300 pretty regularly. So it's definitely tick season, especially with this kind of cool, wet weather. It's providing pretty good, conditions for them. And just kind of looking at our syndromic surveillance data, we kind of look for tick bite encounters at emergency departments, and we are seeing an increase there. So, that's an indicator that people are coming into more contact with ticks. And with that, we did send out 2 health alerts, so 2 HONs here earlier this month, one going specifically over Lyme disease, and then the other going over the other tick-borne diseases, and that kind of gave some guidance and some suggestions for, laboratory testing there. And so, that's kind of what we wanted to bring up is, it is tick season. So you may be getting some, requests for, for tick tests and stuff from providers. So if you haven't, I would go ahead and review that document. It gives some pretty good, information in terms of the labs that should be ordered for supporting laboratory diagnosis. One of the tough things we always get is, trying to get a convalescent follow-up specimen. I always try to encourage providers to get a convalescent. Sometimes we're more successful than other times, but that's something we'd really like to improve on. With that being said, we have seen a couple cases of spotted fever rickettsia as of late. Both these happen to be in children under the age of 10. We were able to confirm one of those. We did get an acute specimen followed by a convalescent. The provider was able to work with us to get that. And so we were able to confirm one of those 2. But, going forward, with the tick season, we'll eventually be transitioning into mosquito season here pretty shortly. We'll be starting our West Nile surveillance at the end of this month. So again, be on the lookout for another health alert coming out for West Nile virus. It's going to be very similar to what we've done in previous years, starting June 1st and going through October 31st. Providers will be able to submit CSF specimens, preferably with a serum specimen as well, to MPHL for suspected neuroinvasive West Nile cases. So be on the lookout for that as well coming up here, hopefully here pretty shortly at the end of this month. And, I think that's all I wanted to say, Karen. Oh, I guess one other thing I did want to mention is that if there's any special send-outs that need to go to CDC for vector-borne diseases and along with other conditions, please make sure that the provider or yourselves reach out to public health to get that permission first. Certain tests at CDC require certain paperwork and certain information, and CDC may not, without that information, may not test those specimens. There may be some requirements that CDC has before they'll even test the specimen. So please, if you have a provider, wanting to test something, one example I can think of recently was for a trypanosoma cruzi specimen a couple months ago for a potential Chagas disease case. It just kind of showed up. There was no notification to public health, and so it kind of took a week's worth of work to kind of track down what was going on and why there was a request for this specimen and all that kind of stuff. So we want to kind of avoid that going to the future here. So if you do have a provider or someone that requests something unique that the regular commercial reference labs can't handle or can't test for, make sure if it's got to go to CDC to reach out to public health first to get that permission and that request. And I think that's it, Karen.
All right, thank you, Jeff. Yes, I'm certainly glad you shared that reminder. My guess is that most laboratories are really good about letting us know. However, it may be possibly the nurses or the physicians who may be sending it directly and don't know the whole process. But it would be a great advantage if our laboratorians could share with each of their physicians especially if they have maybe ID doctors that they work with. Maybe not always, where especially the ER docs, that would be something that you could share with them to say, hey, if you want any CDC testing, please bring it to the lab and then you'll be able to contact us. And two, I also thought that it'd be great to talk about the tick surveillance. I have Jeff talk about it because this is also the time of Francisella, with it being so gloomy and rainy out, and knowing the ticks are a big deal this year. We are kind of waiting for that first Francisella, and want all our laboratorians to be aware of that. If they actually have a very small gram-negative coccobacilli that they might see as a slow grower on your plates, especially your chocolate plate, keep that in mind, that needs to have a little biosafety put behind it, that it does need to be worked up in a biosafety cabinet. If you have worked with it on the open bench, that could be considered a exposure. So that's not what we want. And I think that any of those trigger points, if you can recognize them as soon as possible and do the appropriate workup, you'll all be safe and good. But do let us know right away if you have such an organism. Unfortunately, the stat pack is not up yet, so you will have to use our reserve system, and that would be the 24/7 pager that we have. And either Emily, Amanda, or one of the other girls will be handling it, and will help you with it. So thank you, Jeff. I was going to say, Robin, you're welcome to introduce yourself, but I don't have you on the agenda for any influenza this time.
Yeah, that's totally okay. I like to be left off agendas
Okay.
nowadays. But I guess since I am here, as a reminder for the summertime, if you do happen to see any influenza cases, we would like to get all of the summer influenza specimens to the public health lab for further confirmation and typing. And if you happen to get any unsubtypables on your respiratory panel, please send those in, because we have to be cognizant of potential swine flu cases, H1N1, H3, and 2 variants. And yes, flu started the variant craze. So please send those in if you see any positive flus.
Thank you, Robin. Great reminder too. All right. Matt, I know that we've got you on the schedule next. Are you free?
Absolutely. And I think I've been unmuted this whole time since I joined. So sorry, guys, if you
no problem.
Heard me breathing or typing or something here. Yeah, I don't have any key updates, I think, for this group today. And I'm just general COVID-19 updates. As far as sequencing, I think this is still hugely successful here in Nebraska. And we are finding more than 90%, nearly all of our completed sequences on runs between NPHL, Creighton, and CDC are now variants of concern, and predominantly that B117. We're especially looking to identify P1s, which seem to be increasing in proportion in different regions throughout the US. And B1526, this New York variant, which is increasing in proportions in the Northeast, and more places are now identifying, like us, this B1617 from India. And I'd say that just for a brief update, we know less about this India variant B1617 than others. There was some recent, the only real information I've seen about it from studies is coming out of Cambridge. And it looked like one reason we've been concerned about it is this quote unquote double mutant. It has 2 mutations that are particularly concerning with respect to immunoscape. And this data out of Cambridge is a bit reassuring in that even when you add both these mutations together, it doesn't seem to produce more immunoscape than P1 or B1351 or some of the other 484 mutation variants. So a bit of reassuring news about B1617. However, out of UK, who has kind of led the show and in doing studies on B117 and has been really on top of looking at proportions of their sequence variants, they're finding that B1617 seems to be increasing in proportion similarly or at a similar rate as B117 was in the beginning. So some concerning news about B1617 on how quickly it's moving there, and reassuring news on it's only producing similar rates of immunoscape. But I think those are the only real updates I have for the group on variants.
How are the
Right.
vaccines working, Matt, for the 617?
Not sure. So
Sure.
what we need are population level studies, right, that answer that question across groups of people, and that information hasn't been coming out of India. All we have is this one bench study out of Cambridge, which is our first guess that vaccines should work for it just as well as they're working for P1 and B1351, which overall is still good.
Yeah.
The vaccines are still preventing poor outcomes, severe illness, but perhaps just don't do it to the extent that they are able to prevent it for other variants.
Yeah, okay.
All right, thank you. And I know that the very person who does the testing here at MPHL, our very own Baha, if you are on, I was going to say, do you have anything to add to Matt's comments? Any other sequencing information that you'd like to share? And I might have caught him away too.
I thought he was on, Karen.
Yeah, but
Yeah,
but I know how that goes. So, all right.
Baha, anything you want to share? He's unmuted. No. I could share that Dr. Abdulhamid and his staff have been really busy with sequencing. I think, Matt, you're shaking your head up and down saying, yeah, we're busy. Last week, I believe they ran full runs every single day last week, which a full run for us is 32 samples overnight. And we're getting enough positives that meet criteria for testing, which is good and bad, I guess. We wish it would go away, but we're still getting the samples for testing. We are getting samples not only through the public health lab, but we're getting them from Nebraska Medicine, Test Nebraska, UNL, and other labs in the state that have samples they'd like us to run on the sequencer. So we will take samples from any lab, I believe, that meet criteria for testing if people really want to know what's going on. You agree with that, Matt?
Yeah, absolutely. Happy to take them from anywhere throughout the state.
Yeah. So, and
Pete,
you can work.
would you go through the criteria again just once more quickly?
Well, we want samples that have a high viral load, which would be a CT less than, I believe 28 is the number we're working with now. If they can't get a CT from their COVID testing and they really would like us to do some sequencing for multiple reasons, they can send the sample to us and we will run it on our test to get the CT value to see if we can run a sequence on it. So we will repeat that test for them. At this moment, we're not being overwhelmed, so certainly we would take them and run them. And I believe they have to fill out the NULERT request form when they submit a sample. John, are you on? John Figliamini is our liaison with DHHS.
He is.
Good morning, everyone.
John, you're kind of working with the other facilities for sending in samples. They're all going through NULERT?
Yeah, the vast majority of specimens coming in are going through NULERT. We've had some great work with the other laboratories around the state sitting down, either getting together a manual requisition filled out for the NCO-VFL test, or going through NewLert itself and filling it out digitally. So it's been working very well. Thank you very much, everyone.
Yeah, so if you have questions about getting a sample to us, you can contact us at the Public Health Lab or work through John, and we will work it out with you of how to get the samples submitted.
There's one last thing. I wanted to give Baja a chance, but it looks like that his mic isn't working. I gotta give a little do a little bragging on Baja, Elizabeth, John, and Pete, and everybody. We've been working on refining this process, right? Because we're building this as we're going, just like each of these systems we made. But we had a key identification of a new variant of concern happen within 3 days of specimen collection, and that's a full round trip between patient tested, positive, patient begins isolation, specimen moves to NPHL, specimen sequenced, reported to me, and from me reported back to that public health department so that they can do as much containment around it as possible within 3 days. And when we first started running at this, one of my main goals was to be able to use this variant identification information in real time for public health action, to be able to do even more robust investigations around concerning variants. And a lot of folks on my calls in other states said it couldn't happen because this can't move fast enough for public health action. And I think we're disproving that with this squeaky wheel that this is turning into. So thanks for the whole sequencing team over there and making it move that quick.
And it does help that we have a sequencer that does rapid sequencing, and it does it well. Yeah. Not everybody has the availability of that technology, so it really is helping us in Nebraska.
Yes. Well, thank you for the kudos. Anybody else from DHHS, do they have any other topics that they'd like to speak on? I didn't know Brian Buss, or if anybody else wanted to share anything. All right, hearing none.
Hey, Karen, this is Brian. Sorry, I was having trouble getting unmuted. Too many windows open.
That's fine.
I did want to comment a little bit. I know the last time that we were on, you covered, a little bit on brucellosis, where we had a potential exposure with brucellosis, and I wanted to comment on brucellosis, where even though it is a kind of a tricky bug to work in the lab with, it is one that there is a fair bit of value to learn which species it is. It is one where, a lot of times we'll see a diagnosis just with serology, but whenever we can get lab work done to definitively identify the species, it's really helpful. Whether it's Brucella abortus or Brucella melitensis. A lot of times Brucella melitensis is an introduction, a lot of times with exposures that occur in Mexico or outside the country. Another concerning exposure would be, though, to RB51, which is the vaccine strain that's used routinely in cattle, and there have been instances of RB51 infections in people. And another thing that we've kind of dealt with recently is some diagnosis of Brucella canis in some dogs in the state. So Brucella canis is also potentially zoonotic and a very challenging one to isolate in humans. So as much as it is a risk to laboratorians, it still is important to try and get a diagnosis in a culture. And working with the public health labs is a really good way to initiate those processes. Thanks.
Yes, thank you, Brian. That definitely has been on our mind, and it hasn't been just one species. And it used to be that we would have a Brucella once every 10 years, but that certainly has increased. I mean, I think we've had it every year, if not every other year. So it's good for our laboratorians to know, especially if the physicians try to order brucella serology, ask them to contact the state, and we will see what else can be done to assist with the diagnosis. So, but again, it is definitely a hazard to our laboratorians, and it's definitely something, again, being a slow grower, that we want to really stress and push upon, that anything that you have, even the slightest inkling, to make sure and work it up in the biosafety cabinet. And I do have a BT class coming up soon that I'll be speaking of here in a few minutes. But as I look at the agenda here, I know going down to our NPHL status, Pete, thank you. I know you and Baha pretty much covered new variants already. Is there anything else in the laboratory world that we need to share with our partners out in the field?
Karen, do you hear me?
Yes, we can, Baha. Go ahead.
Okay, well, sorry, I don't know why the microphone is not working on my side. Last week, it was working fine. Actually, Matt and Pete did an excellent job updating us on COVID-19. It's very hard work. It's a great teamwork. And actually, the COVID B1617 that we identified last week, it helped us in two levels. First of all, we detected the first case in Nebraska. Second, I knew through our friends in San Francisco that there is a new website that I didn't know about before, and no one told me about. We can get the lineage for all strains we have. So we're going to add one more line, so to speak, or level of our identification for our strains. And it will make our life way easier, especially me, because Matt and Pete and the rest of the team know when through Nextclade, it gives you like 3 different levels of the sequence: good, bad, and mediocre. So for the bad and the mediocre ones, I used to go through hundreds of mutations to give the call. And just last Tuesday, I think, or Wednesday, with the first variant, or the Indian variant, I suspected the strain, and I was scared to give it a call on my own. So I contacted the Gridiron Clear Labs people, and they told me, well, even though we have only 6 out of 10 mutations, but we are confident it's 617.2. I told them, how can you be sure? So they gave me this website. So we're going to add this website to our reporting, and it will save a lot of time, and it will solve any discrepancy we have. Even though over the weekend, actually, we had a 1 VBT case between us and CDC. CDC call it R1 lineage, while this software or website call it B1596. I don't think it's a big deal, but discrepancies sometimes happen. But it will save a lot of our time and effort, especially on the bad and mediocre sequences. And I need to mention about Elizabeth. She's working, all of us are working really hard on this. She is doing fantastic job. Like last week, she did like 5 runs in a row in 5 days. And the sequence assembly coverage of our sequencing are now 30 out of 32. We're getting them like in good shape, which means 98% and above, which is a great sequence. We have been getting that frequently the last 2 weeks, which will make our life even way better. And thank you very much, all of you, to listening for me.
Great. Yeah, that's very interesting, Baha. So I apologize. I did not see your message that your mic was not on, but I do see it now. And that leads me to mention that there are a few other questions for our NPHL staff. I think that we could go on. Dan Engel out of David City, am I correct on that? Does have a question for RPS and for us about stool testing, and should they be testing, or should they be submitting the samples to NPHL if indicated? Pete, would you like to take that one?
Karen, we can't see the question. I think it was sent directly to you. Could you
Could have been, right.
read out what the full question was?
It says, if RPS does all the stool testing, will they submit sample to NPHL?
Pete, I can take that one if you want. Yes, if you submit a stool to RPS, if you are not able to isolate the organism yourself, you can submit the stool to RPS. RPS will work to get that isolate taken care of, and then we'll transfer the isolate to us via state law as well. So as long as you submit that stool, it will make its way to us if we are able to isolate that organism.
Exactly.
So this is Brian Lenz, just following up if the account or if Dan in David City is sending a sample to us for stool culture, we're now referring our stool cultures over to Methodist Hospital. And if they come up with a positive that's from that stool culture, they're acting as our reference lab, and they should be sending it back to public health lab as per the instructions for reportable diseases.
Perfect. Thank you, Brian. I was going to bring that up, but I'm glad you did for sure. So that's good to know. And the only reason that Methodist is helping it out is because during COVID, our team, being very swamped, was not able to continue on doing stool cultures here on site. And that is something that maybe in the future we will do if we can, but it may also, for now at least, it is at Methodist Hospital. The other thing I see on chat is that John, when we were talking to him and talking about shipping isolates to COVID isolates for sequence testing, that you can refer to John, just contact him, and that contact information is in our chat box for everyone to see. So, Brian, since you were on, is there anything else client service wise that you'd like to share with us? How are things going? Any issues that you foresee and need to discuss?
So I'm not aware of any major issues to discuss. Jessica Carr doesn't look like she's on, or Teresa Fowler, but I noticed Tony's on. So Tony Goldenstein may want to chime in too. But
I'm not aware of anything for the group, no.
Yeah.
All right. And I know Tony has always helped us with some of the COVID rapid testing out in the field for the Binex ID testing. Does anybody have questions on that kind of testing that Tony has been handling? Are we almost up with the expiration dates on yours, Tony, if I remember right?
We have some June and July.
Okay. So maybe another month worth. Okay. All right. Does anybody else have any questions that they'd like us to handle or try? Okay. Hearing none, I just have a couple of other items to add, and that would be that we are thinking of doing one other communication drill here. I didn't get first quarter done, so definitely we'll try to do it here beginning of second quarter of the month or the year. What that entails is we do send out an email that when you receive it, if you could answer it as soon as possible. We usually try to add one topic to it and use it as a survey. I think this time we will use it for assessments needs. To ask about biosafety, I think we can all kind of, not that we can sit back because COVID is declined. I think we're all still very busy, but it might be worth taking a breath and discussing amongst yourselves what your changes have been in your biosafety world, and if you need some assistance with it, do you need some training? What kind of instrumentation or lab supplies could you use to better your surroundings, make them more safe? So I would like to try to work on that here in the next month. Might be another question or two on COVID testing itself. So please do anticipate that. Please don't ignore that question. It really does help us to know what to discuss during our meetings and what education we can bring to you in the field. And trying to think if there's anything else. The CDC One Lab has been going for several months now. I have been listening to their webinars, and in reality, they've been excellent sources of information, just even for me. These One Lab committees, I guess I'll call them, are designed after COVID to really be a way for CDC to reach the clinical laboratory directly. So I invite you to look over the past meetings. You can click on those links and you can download the slides or listen to the audio portion of their previous meetings. And I guess I don't have their next meeting on, but I'll be happy to share that with you also if you're interested. Excuse me. In regards to education and training, my rule out and refer workshop, I had originally hoped I could do it this month, but as it turns out, I did end up doing quite a bit of biosafety training, and I am now postponing that to mid-June. I believe that I'm going to try to spread it out a little bit. It is 3 classes that I would like to make sure that people are able to manage all 3 of them. So it might be like on a Wednesday. I don't know if there's any good particular time. I don't know if over the lunch hour is the best time, but it seems like that's the one time I can catch people. Please let me know if you have a preference for that training, and I look forward to advertising that here now in the next week. Once the the BT training is completed, I will be handing out the challenge set exercises. Anybody who has taken the class, I hope that they are asked to work on that challenge set, and it will be good practice for them after they've done the training. With that, I don't have anything else to share with our laboratorians, so I'll open the mic and see if there's other topics that any of you would like to bring up. I don't see any on the
Karen,
chat box. Go ahead.
Pete. Just as a little preliminary study that we're doing in the public health lab, I just wanted to share a little bit about some testing that we're doing with the EIA test for cryptosporidium. I don't have all the results available, so I can't give you what we're finding because we're still working on this. But what we've done is over the past year, we had a number of cryptosporidium positive stools sent to us that were positive by the EIA test. and we were unable to get a sequence from those particular stools. So what we've done is we've rerun those stools on a PCR assay, the BioFire GI panel, and found out that all of them, we ran 13 of them, all of them either had other pathogens detected or nothing detected, no cryptosporidium. So we're looking at this further, but I just want laboratorians to be aware that we are seeing, apparently are seeing false positive results on the EIA test for crypto that are not crypto. And I don't have, again, once we get more results, I can share this more with the laboratorians, but keep that in mind, you folks out there that are running this EIA test and you want to maybe question your result, you could send it here to us and we could run it on a GI panel to get a PCR test done as well. So keep that in mind.
Oh, Pete, I'm really glad you mentioned that. I think it's very important. I think that test has been somewhat questionable for a long time. But crypto is such a huge part of our state and some of the outbreaks that we incur.
Yeah, of course, when they're called positive, then there's an epi investigation that has to go on. So there's a lot that goes into this. Interestingly, the 13 that we ran last week, 2 of them were cyclospora, not crypto. And I think at least one of those, Emily, you can correct me, but at least one of those actually fits the cyclospora outbreak that we had last year.
That's correct.
Yeah.
Wow. Interesting.
So interesting results.
Okay. I'll turn it back to the audience and see if any of our clinical laboratorians have any other good topics or questions.
Karen, I just wanted to add a few things. I know we mentioned sending things to the CDC during Jeff's update, and I just wanted to remind all laboratorians on the call that anything at all that needs to be sent to the CDC, not just things associated with Jeff's update, do need to be funneled through the public health lab. We are kind of the gatekeeper for everything going out to the CDC. So if the CDC encounters any questions or anything, they know who to call for that and who to send the reports to. So we are their point of contact for that. So please work with us to ensure that you have appropriate approval and everything. Those specimens would then be sent to us here at NPHL, and we would go ahead and coordinate the shipment to the CDC once all information and approval is obtained. And then I just wanted to say thank you for the reminders on Francisella and Brucella. As you know, those are both big organisms here in the state, and the reminder to follow your rollout and refer training that Karen has so greatly provided. Please keep everyone safe. That's our #1 thing here, is to help keep all of you safe. And we can go ahead and take any testing that you guys don't feel comfortable with if it meets those guidelines. And then finally, if there's anything else that you guys have any questions on in the state, any trainings that you see a need for, even if it's something as simple as you have, especially in the time of COVID, if you have like a supply that you can't get your hands on, please let us know and we can see if there's any way we can assist you in that.
Excellent, Emily, thank you. Yes, all good reminders. And in regard to the BT training, I was going to say when we have that in June, something I'd like to see that I don't think is very frequently used in the field, and that's, do you have webcams? If you're listening to our Zoom trainings, sometimes it helps to have a webcam. And we'd love to see your smiling face, but even at that, it just works better. So if you need a webcam and don't have it, I think I'm going to try to maybe offer a couple if you do take that BT training, because it works out easier. It's going to be a very interactive training, and hence it just makes it ever more interactive then. So. All right, if no other questions, please don't forget to sign your name again. If you came on late, please sign our chat box. Just let us know what facility you're from. Our next meeting will be the 3rd Monday in June, which happens to be June 21st. So we'll see you then. Hope it stays quiet until then. And we appreciate everybody joining us. You all take care now. Bye-bye.